Hello and welcome. My name is Matthew J. Greer, and today I will be presenting my topic of the electrocardiogram. This is for Biology 520, Concepts of Human Physiology 2, through Grand Canyon University, and my professor is Dr. Sandra Barrera. And this is recorded on January 12th, 2022, which is actually my birthday. But without further ado, let's jump right into the electrocardiogram. So what is an electrocardiogram, or sometimes abbreviated ECG? Well, the heart is an organ in the body that pumps to spread blood throughout the entire system of the body. It's going to push this blood through all kinds of arteries and veins, and keeps oxygen supply up to the brain, keeps oxygen out to the fingertips, the toe tips, all the organs, keeps them going. Now, this is done as this heart muscle is contracting. This is response to electrical currents inside of the heart. And as these electrical currents drive the depolarization and the repolarization of the heart, some of this travels through the liquid parts of the body and reaches the body's surface. In a typical electrocardiogram, there are 12 leads. There's one on each limb. We're not going to count the one on the right leg when we're counting them, and we're going to count these V1, V2, and V3 twice when we count for 12 because they are bipolar. They are, bipolar leads with 2 electrodes each. So there's 1, 2, 3, 4, 5, 6, and then 7, 8, 9, 10, and 11, 12. The reason we don't count the right leg is because this is used as a ground and is not actually used to record any electrical information. Now, the electrocardiogram is measuring differences in electrical current. So some considerations for this is only the electrical activity reaching the surface is recorded. These are not probes that are being injected into the body. These are patches on the body. So it has to reach the surface. So any electrical current that doesn't reach the surface is not going to be recorded in an electrocardiogram. Another thing, the electrocardiogram isn't a recording of a single action potential. It is the summation of all of the action potentials happening at the heart at once. We're going to talk about later, there's some electrical activity that's masked because there's much larger electrical activity happening at that time. And another thing to consider is this recording measures electrodes at 2 points. So once again, we're not measuring the actual heart muscle, we are measuring the signals that we receive from that kind of action. So the anatomy of the electrocardiogram. There is a P wave, which is this first part here. There is a QRS complex, which is this guy here. And there is a T wave on the other side. We're going to talk about these segments, of which there are 3, in a little bit. But to begin with, we're going to talk about what is a P wave. What does the P wave mean? What does this electrical little bump here means? Well, when the heart is going about and it's got its nice 4 chambers, those 4 chambers are going to work together to pump blood. So if I draw this little box of the heart up here, we have the left ventricle, the left atria, the right atria, and the right ventricle. So the heart is going to squeeze as it's getting blood in from either the body through the vena cava or from the lungs, from the pulmonary vein. It's going to get blood into those atria, and those atria are going to need to squeeze and help kind of pump that blood down to the ventricles, and then the ventricles will fire, pumping that blood to the body, either, in the case of the right side, back up to the lungs after it's been through the body without all of its oxygen gone. It'll send it back up to the lungs, get more oxygen, and then come back down in this pulmonary vein. And the other side, it's going to send this out through the aorta to the body. So we need to have this kind of coordinated beating of the heart. We need to make sure all the blood gets emptied each time. We need to make sure it's a very efficient system. The human body is very big. The heart has a lot of work to do. So first, we see the P wave. We see those atria contracting and kind of squishing that blood. We don't see the sinoatrial node, which is up here, because there's not enough electrical current that's reaching the skin. That's one of those considerations that we were talking about. It happens. There is electrical current happening there, but we don't see it until this larger depolarization of the atria actually occurs. As this goes through the atria, this now goes down to the ventricles, and we get this big QRS complex. This big QRS complex is the ventricles depolarizing. And then this T wave is the repolarization of the ventricles. At the end there, we don't see the repolarization of the atria because it's hidden by this really, really big QRS complex here. And the reason this QRS complex is so much bigger than the atrial, the P wave, is because these have a lot more, they're pushing blood a lot further. The atria are going a very small ways from one chamber of the heart to the other, and the ventricles are pushing that all throughout the body, to the lungs, all the way up to the brain, all the way down to the toes. So they need a lot more force, and because of that, there's a lot more electrical current and a lot more electrical difference happening. There are 3 times of no net current, and this is one of those considerations we talked about. If there's no net current, then there can't be any kind of ECG reading. And this is, the first one is the PR segment here, in between these atria depolarizing and the ventricles. There's this segment where these atria are fully depolarized, and there's no electrical current happening here. There's this ST segment, where once again, the ventricles, after squishing, are now fully depolarized. So they are done there. They've squished all that they can. And then they start to repolarize here. But in between here, there's no electrical activity. They're all the way depolarized. There's no difference in electrical activity. And then this TP segment, which goes from here back around and then starts over, there's also no electrical current there because this is when ventricular filling is happening. So we are getting back up to full. We're getting ready to pump again. Everything's like filling up, getting ready, getting that blood in there, getting ready to squish again and start the process all over again. So abnormalities in the ECG. There can be abnormalities in the rate of an ECG. Normally, this top kind of picture here is a normal ECG. And as you can see, it's got this QRS, very, very standard, very same distance apart. And in all of these, the QRS is going to be the same distance apart. But what's different is this T to P section here. As we get done with our repolarization, it takes a lot shorter in tachycardia because we are faster heartbeat, is a lot shorter time, so that it's happening faster. It's getting that QRS, ventricles, 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 versus bradycardia, where we are much slower, which is that pumping of blood, and then that long wait here, and then that pumping of blood, and then that long wait here. So somebody with tachycardia would have a abnormally high beats per minute, and someone with bradycardia would have an abnormally low beats per minute. Now, the second type of abnormality we can have is in rhythm. And in normal rhythm, all of these complexes are very evenly spaced. They all look the same from each individual heartbeat to the next. And in arrhythmia, or no rhythm, anytime you see that A in an anatomy class, that means that it is not. So avascular means no blood, arrhythmia means no rhythm. So in this one, all of the complexes are normal. They're all the same right size and shape, but they're not always in the same distance apart, there's some weird, like the heart's going pump, pump, and then a big wait, and then a pump, and then another big wait. So it's an irregular heartbeat. It's not evenly spaced. Even in tachycardia and bradycardia, those were at certain intervals that were happening and repeating at all times. So there are two types of, there are different types of arrhythmias. One of them is atrial fibrillation, which is where we're getting this very irregular kind of zigzaggy pattern here, where it's really hard to figure out where these P's are. It's because the atria are firing fast. In atrial fibrillation, these atria are firing kind of uncontrollably. The ventricles are still firing at the same time, and they are very uniform. That QRS looks really nice. Excuse me. Yep, that QRS looks really nice. It's happening at the same distance apart. And then in ventricular fibrillation, this is where we get this very wide, rapidly, like oscillating complexes, as the ventricles are beating as fast as they can and not giving anything else. Like there's no other electrical activity being recorded here, because once again, the ventricles have a much larger peak than the atria. So they have a much larger difference in charge. So they're hiding all those atrial instances in the heart. In our last abnormality, cardiac myopathies, these are things like myocardial infarction. And in this example, where we have our normal baseline of this T here, this ST elevation, where it's normally down here and then a little hump. Now it is a much longer, prolonged thing, as it is taking much longer for those ventricles to repolarize due to necrotic tissue. For another pathology, we're going to talk about Welland Syndrome. Welland Syndrome affects the left anterior descending artery of the heart. The left anterior descending artery is this one right here. And it is important, after it breaks off of the left coronary artery there, it pumps blood to the heart, specifically the left-hand side of the heart. Remember that when we're looking at the heart here, on your right in anatomical position, this is a left-hand side heart. And on the left here, this is a right-hand side heart in anatomical position. There are two types of Wellens syndrome, and both of them are affecting this left anterior descending artery. And it's also very important to note that without oxygen to these cardiomyocytes, we're going to lose function. And when we lose function, we lose oxygen, we lose blood pressure, and it can be the process that starts a myocardial infarction. So catching these instances early is a good idea. And that's something nice about Welland syndrome, is it kind of gives us some tools to catch these early. There's two types of Welland syndrome. There's type A and type B. Type A is less common and has biphasic T waves here. As you can see, they're very abnormal compared to a normal ECG. Type B is more common. It's easier to, let me get rid of this yellow thing there, sorry. More common, it is easier to recognize, and it has these inverted T waves, especially in leads 1, 2, and 3. So these ones here have these inverted T waves that are going way up compared to the other side, which is having these T waves going down. So in their paper, Arisha, Halak, and Khan from 2019, they did a case study on a 30-year-old patient who presented with chest pain. He had palpitations, he had nausea, and he didn't have any prior history of these symptoms. He was an occasional marijuana smoker, but didn't have any other risk factors for coronary disease, and he had a clean physical examination. When he was admitted, his ECG showed T-wave inversions, and a stress test was ordered to kind of see if they could get these symptoms to come back out. And that stress test, they actually had to end up finishing early because they exacerbated his symptoms and brought those back up. And then after they did a coronary angiography, they found that he had 95% obstruction in his left anterior descending artery, which is what was causing this Wellens syndrome. the patient was given a drug-eluting stent, or a DES, and they look like this is how they work, where they're inserted with a balloon in them, and then that balloon gets blown up, and then the balloon gets taken out after it gets deflated, and this stent is left. And the DES, also in kind of as working as a support, it also eludes a drug. So it's going to release a drug, helping to prevent the proliferation of tissues in there. And this will slowly happen. And the importance of this study and the importance of catching this is Welland syndrome and this abnormal T waves can occur in an individual who is not showing any other symptoms at the time. This patient came in with symptoms, and that's what probably led them to go and order all these tests. But if they had symptoms a week ago and they're just now getting in and complaining about it, Wellens syndrome could give you valuable information about what's actually going on inside of that patient's body and what actually is happening. And it's a warning sign for myocardial infarction, so catching it early is better. Leads to more patients surviving, and that's always a good thing. I hope that through this presentation you learned about the ECG, you learned how to read them, you learned what all the letters mean, the PQRSTs. I hope you learned what a normal heart rhythm looks like, what it means when that speeds up, when it slows down, when it changes pace, when it has weird, irregular patterns. And I hope you learned about Welland syndrome. References, the Welland syndrome case study is this rare presentation here one by Arisha, Halleck, and Khan. It is a great resource if you want to go read more about that and read some primary literature. And then for the bare bones physiology and anatomy of this, you can reference the textbook by Sherwood. It's got lots of good information in there. Gives a basic synopsis of how an ECG is done and how the leads are set up, and some basic problems, including a couple that I didn't discuss today. I hope you enjoyed this, and I'll see you next time.